exclusion, meaning a definitive diagnosis of leukoplakia is rendered only after other white lesions have been excluded. There are several white lesions that mimic leukoplakia. Firstly, check if the lesions are removable with a plain white gauze. Chances are it could be pseudomembranous candidiasis if they are. If the lesions are on sites prone to trauma from teeth, dentures, or other appliances, they could be frictional keratotic lesions appearing due to mechanical trauma. Lesions on the commissure could be hyperplastic candidiasis. Candidal hyphae, if present in cytology or biopsy, could confirm the diagnosis. Hyperplastic candidiasis could also occur on the tongue and is not scrapable, unlike the pseudomembranous type. Other unilateral lesions that have to be ruled out are chemical burns, linea alba, and lichenoid lesions due to restorations. Oral lichen planus characteristically manifests with a reticular striae and occasionally has plaques. Check for skin lesions and other clinical variants of lichen planus if in doubt. White sponge nevus and hereditary benign intraepithelial disc keratosis occurs most commonly in the buccal mucosa bilaterally. These lesions are shaggy, wrinkled, not well circumscribed, and occur usually in early childhood. Pale, milky whiteness that disappears on stretching could be leukodema. Also rule out cheek chewing, where patients have a chronic habit of chewing the buccal mucosa. Presence of bilateral, corrugated, wrinkled white lesions on the lateral border of the tongue could signify high leukoplakia. Now, these are not true leukoplakias and are not potentially malignant and frequently occur in HIV-positive patients. Nicotine stomatitis is a generalized white keratosis on the palate with scattered red spots representing the inflamed minor salivary gland ducts. Now, this lesion seems to be a response to the heat produced due to smoking and not to the chemical carcinogens within the smoke. It is not leukoplakia and it is not potentially malignant. Now, tobacco pouch keratosis, frequently misdiagnosed as leukoplakia, manifests as a fissured, wrinkled pouch with or without areas of white patches in the vestibule where the tobacco constituents are chronically pouched. This has a characteristic clinical appearance and should not be misdiagnosed as leukoplakia. It has very little potential to become malignant, if any. Now, besides clinically ruling out these lesions, biopsy must also reveal a diagnosis that is compatible with a clinical diagnosis of leukoplakia, meaning the lesion under the microscope must not reveal any other microscopically definable lesion. Say, for example, if a plaque-type oral lichen planus has been misdiagnosed as leukoplakia, microscopy would obviously reveal oral lichen planus. In 2002, Van der Waal and Axel proposed a system for reporting leukoplakia to maintain a uniformity in diagnosis. They recommended a distinction between a provisional and a definitive diagnosis of leukoplakia. A provisional diagnosis is made when the white lesion in question cannot be diagnosed as any other clinical entity on initial clinical examination, applying only inspection and palpation. A definitive one is made after elimination of suspected etiological factors and other lesions during a follow-up of at least 2 to 4 weeks and complemented by a microscopic diagnosis where any other definable lesion is ruled out. To make things clear, let us suppose a provisional diagnosis of leukoplakia has been made. If there are no possible etiological factors causing this lesion, it could definitely be diagnosed as leukoplakia. Now, after eliminating the possible etiological factors like habits or a source of trauma, keep the patient under follow-up for a minimum of 2 to 4 weeks to see if the lesion shows signs of regressing. If yes, chances are it could have been a reactive lesion like frictional keratosis or a tobacco pouch keratosis. If there are no signs of improvement, perform a biopsy to check for a histopathological diagnosis consistent with the clinical impression. Biopsy should reveal either a hyperkeratotic lesion without dysplasia or an epithelial dysplastic lesion. If it reveals any other definable lesion, then it has to be understood that clinically the lesion was misdiagnosed as leukoplakia.